You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for August 18th, 2023. This week, we're talking the ICD Gen Change, less is more in management of VT, comorbidities in heart failure, and SGLT2 inhibitors after AFib ablation. First, a note of thanks. TWIC podcast received a number of comments on the website and a few reviews on the Apple Podcast app. Thanks for taking the time to write. It's nice, and it helps us reach more people. Another note before I start, I am trying to name authors and I often have bad pronunciation and I apologize in advance. We start today with one of the most common and important decisions I make in the clinic, the ICD generator change. And I am not an outlier. Nearly 1 in 4 ICDs implanted in the U.S. are done during generator changes. Now, this may seem like a niche topic, but it is not. This may be one of the most important 5-minute topics I've done all year on this podcast. The ICD generator change is a massive blind spot in cardiology. A very nice paper stimulated my interest, but first some background. The ICD, or implantable cardioverter defibrillator, has been a great innovation in cardiology, right? Seminal trials done 20 years ago showed robust mortality reductions versus medical therapy in patients with heart failure, though most of the benefit occurred in patients with ischemic rather than non-ischemic causes of heart failure. Patients in these trials were relatively young and relatively free of comorbidities. They were also ambulatory, outpatient heart failure patients. Now, what I want to say now seems almost too obvious to state. Patients who have ICDs age. As humans accumulate birthdays, they also accumulate comorbidities. Battery life in the ICD is about 8 to 10 years after a primary prevention ICD and 8 to 10 years after the initial ICD implant. At the time of battery depletion, the health situation is often changed. For instance, the risk of VT-VF may be different, the risk of the procedure, quality of life, and comorbid conditions all may differ from the primary implant. Here is just one example. The left ventricular ejection fraction may have improved since the ICD implant so that this patient would no longer meet eligibility requirements for a new ICD. Also, what if the patient has had 0 therapies in 10 years? What if it's their 3rd gen change and still have never had a VT therapy? Yet, what happens way too often is patients are told that their ICD has a low battery and they need a new one. They're often told it is an easy operation, and it sort of is, except that the downside risk is far greater during a gen change. Guess why that is? I can wait. The reason is that if there is an infection during the gen change, the 10-year-old leads have to be extracted, and that is a big procedure. It requires doctors and labs and staff with a lot of experience. I like to say it is a low-risk event with asymmetrically terrible consequences. Now, what's crazy is that there has not been a shred of evidence to support ICD generator surgeries ever. Exactly 0 RCTs have been done. I propose that this may be one of cardiology's biggest blind spots. Now, maybe you don't believe me about the equipoise here. Let me cite some evidence for the equipoise. First, consider ICDs in non-ischemic cardiomyopathy. Most of the data supporting this is weak. Remember, MADA-2 trial was all ischemic cardiomyopathy. There was the definite trial, which preceded SCUD-HEFT. This was a trial of ICD versus medical therapy in non-ischemics. It did not reach significance. SGLT2i, seminal trial, had 50% of non-ischemic patients, but when they did subgroup analysis, that did not meet statistical significance. The strongest evidence, of course, against the average benefit in non-ischemics was Danish. This was 2016, 550 patients with non-ischemic cardiomyopathy, absolutely no mortality difference of the ICD versus conventional heart failure therapy. And I have one more, a reference that I did not recall. Get this is Jeannie Poole, Jack, 2020. This is 11-year follow-up from SGLT2i. Just when you'd be considering a gen change, right? 10 to 11 years for primary prevention ICD. They found that the mortality reduction held up on average, though there was a decrease in effect size after 6 years. Quote, when the treatment benefit was examined post hoc as a function of time since randomization, we observed an attenuation of the ICD benefit after 6 years. Less than 6 years, the hazard ratio is 0.75. Greater than 6 years, hazard ratio 1.09. P-value for the interaction highly significant. So there does seem to be attenuation of effect over time. Now, you might still argue with me that we can't study this because patients are attached to their ICD. You can't just not replace it. It would go against their wishes. But here, this is where the new study comes in. The first author is Sarah Montembeau from Emory University. The paper's in Circulation, Quality, and Outcomes. Their question was how patients make ICD Gen Change decisions. And they recruited patients over a long period of time, 2013 to 2021, and they completed in-depth interviews about their ideas on Gen Change. The interviews had both open and closed-ended questions. Things that they focused on were subjective understanding of the Gen Change, what were the factors driving the decision, what was the patient's willingness to forego a Gen Change based on sudden cardiac death risk, and also clinicians' recommendations to say not have the procedure. To investigate the benefit thresholds for pursuing Gen Changes, patients were presented with a standard gamble-type hypothetical scenario where they varied the 5-year sudden cardiac death risk 10%, 5%, and 1%. Their survey included 50 patients. Most of these were older than 65 years. 17 of the 50 patients in their series had improved their ejection fraction. That often happens, by the way. They report really interesting findings. First, as sudden cardiac death risk decreased from 10 to 5 to 1%, the number of participants willing to undergo a generator change decreased from 48 to 42 to 33, respectively. Second finding, when a clinician recommended against the Gen Change, only 17 of the 50 patients still wanted it. And of the 33 who said they would get a Gen Change at a very low sudden death risk of 1%, only half, 16 of these patients, would still want the Gen Change if the clinician recommended against it. Wow. Now, they also looked at other qualitative factors that played into the patient decision. These included the probability data, but also prior experiences with a device or implant, like previous shocks, etc. The research team also picked up a lot of misconceptions about quote-unquote needing the device for survival. They also noted this concept of therapeutic inertia, such as just wanting to continue the same therapy. That was also common. All right, what are my comments? What got me pointed to this study was the excellent editorial from Dr. Stacy Howell and Eric Stecker, and they titled it, quote, just a generator change. That's not allowed in our laboratory. We never say those words. I'm going to link to the editorial. I think it is open access. It is a really excellent piece, and it reminded me of this major blind spot in our field. Sudden cardiac death risk is decreasing over time in heart failure. Danish and the long-term follow-up to SGLT2i strongly argue that even de novo primary ICD implants might not add much to the excellent heart failure therapies that we have now. But a Gen Change is even more complicated because of the downside risk of infectious complications and increasing comorbidities of patients after 8 to 10 years of the initial implant. We 100% need RCTs for ICD Gen changes, especially when they're being changed in primary prevention patients, especially when there have been no therapies for VT, especially when they're in non-ischemics. Now, can one be certain about equipoise? Yes, I'm about 99.9% sure there is enough equipoise here to conduct a trial. Of course, due to the lack of industry confluence of interest, for example, they don't fund studies that could decrease the number of units sold, this trial would have to be government funded. Young researchers should start writing grants for this study this weekend. And of course, you can email me, I'll help. Now, the other major message of this paper is that patients' attitudes are not a barrier to good decisions at gen changes. When educated properly, many, if not most, might change their views of having surgery, and I've witnessed this firsthand. This paper clearly shows that our field of EP, really all of cardiology, should intensify efforts to inform patients before a gen change. I like to start these discussions many years before the battery depletion during normal ICD follow-up, so it's not such a big shock. As in, when I'm seeing patients, we don't necessarily have to replace this when the battery depletes because things change. We can talk about it then. At a minimum, all patients at battery depletion should have an outpatient office visit in regular clothes before gen change surgery is even scheduled. All right, second topic, another arrhythmia topic, but this is one that melds into general cardiology and also the establishment of dogma. This is dealing with VT management. Here's another common scenario in the hospital setting. A patient with a previous history of structural heart disease presents with sustained monomorphic VT. They were fine until they had the VT, but in VT they feel awful, chest pain, breathing difficulties, lots of symptoms. What happens in your hospital? Well, in ours, most of these patients go to coronary angiography. Why? Because of the idea that ischemia causes the VT. Now, while it is true that acute ischemia from plaque rupture may cause VT, that's usually polymorphic VT or VF, the sort of R on T looking stuff. Monomorphic sustained VT is almost always from re-entry within a scar, and it's often an old scar. Why old? I don't know, but often these are very remote MIs where the VT comes from. The EP group at Cleveland Clinic has published a very nice observational study. First author, Faris Al-Khalili, sorry for the mispronunciation, supporting what most EP doctors believe. That is, in patients with monomorphic VT, just get the electrophysiologist involved and avoid the delay and risk of coronary angiography and or PCI. The group looked at nearly 100 consecutive patients with VT who did not have ACS who went to VT ablation. Now, these were patients with sick ventricles, mean EF 30%. 2/3 were ischemic and heart failure patients. Nearly half of the cohort at Cleveland Clinic, right, an enlightened place, underwent coronary evaluation. Angiography in 10%, nuclear studies 26%, and both 9%. The yield of these tests was super low, 0 acute coronary occlusions. They found no associations between ischemic evaluations and acute ablation outcomes or mortality. 4 patients of the initial 97 had revascularization with PCI. Get this, sit down for this. In all 4 patients, VT recurred after revascularization in patients ultimately underwent ablation. The authors also added a second cohort of 91 patients that were admitted to the CCU for VT during the same time period. These patients were not necessarily destined for VT ablation. Many were medically treated. In this cohort, about half had coronary evaluations, about 46 patients. 5 of these had revascularization for chronic stable angina. And, get this, 4 of the 5 had recurrent VT. My comments. First of all, this is a good use of observational data, right? They aren't making non-random causal observations. They're describing a large case series, which is useful. I think you have to combine their findings with the baseline knowledge that monomorphic VT is almost always a scar-related problem, not an acute or subacute ischemic issue. And of course, if that is your baseline thinking, then these observations only strengthen that belief. They found 0 acute occlusions. They found no association with ischemic workups and outcomes, and nearly every patient who had revascularization had recurrent VT. Why? Because they found incidental coronary disease and it wasn't the cause. Now, I am not sure I would want to proscribe ischemic evaluation in all patients with monomorphic VT, but we really need to stop and think about the knee-jerk idea that VT means evaluate coronaries. And by the way, I also see angiography used in cases of clear-cut normal ventricle VT in young people. That too is a practice that should be rethought. Now, the first thought one should have when a patient presents with monomorphic VT after the ABC type resuscitation ought to be getting an electrophysiologist involved quickly. I thought that before this series, but this data bolsters that view. Now, critics might push back and say, come on, Mandrola, this is just a small observational single-center series. We surely need better data. And okay, I also think we could study this question in pragmatic RCT form. And here's an example of a protocol. We could get a bunch of VT centers to participate. One group of patients with monomorphic VT gets usual care. The other group gets an immediate call to the EP team. You could look at acute outcomes and rates of coronary angiography. The problem many of us EP docs have is that we don't see the patient until after they've had coronary evaluation or angiography or PCI. All right, third topic today is really important, for me at least, comorbidity in patients with heart failure. Oh, I did not know of Hull, Hull, in the UK. That was not until I read a very nice paper from a group from the University of Hull on hospital admissions in the last year of life of patients with heart failure. The first author, Alexandra Abel, was published in the European Heart Journal Quality and Outcomes. Their idea was to look at the frequency, causes, and patterns of hospitalizations for patients with chronic heart failure in the year before death. Now, this will be another good use of observational data because it describes patterns. Here, patterns that I am afraid heart failure treatment enthusiasts don't often put up on Twitter. Their series included nearly 5,000 patients referred to their heart failure clinic over 20 years. They separated a group into HFpEF with lowish BNP and HFpEF with highest BNP. Well, this is sort of a follow back type study from death backwards. They then classified hospital admissions in the last year of life as due to heart failure, other cardiovascular causes, or non-cardiovascular causes. The median number of hospitalizations in the last year of life of this series is 2. Now, before we get into the causes of the hospitalizations, let me remind you of my palliative care wife Stacy's 4 horsemen of the apocalypse. That is weight loss, immobility, falls, and repeat hospitalizations. When you see any or all of these, it is time to think of palliative care, which she calls PALS for people with serious disease. So in this series, 83% of patients had greater than 1 hospitalization, but only 20% had greater than 1 heart failure hospitalization. Let's repeat that for the heart failure community. 83% of patients had greater than 1 hospitalization, but only 20% had greater than 1 heart failure hospitalization. Second finding, 24% had greater than 1 cardiovascular hospitalization, 70% had greater than 1 non-cardiovascular hospitalization. Heart failure hospitalizations were most common in patients with HFrEF, but in all 3 groups, at least 2/3 of admissions were for non-cardiovascular causes. There were 16% of deaths due to progressive heart failure, of which 74% occurred in hospital. Now, they have this amazing bar graph figure listing the causes of death. The bar depicting non-cardiovascular causes dominates all types of heart failure, but especially in HFpEF patients. Their conclusions, quote, for patients with chronic heart failure in the last year of life, most hospitalizations for non-cardiovascular causes regardless of their heart failure phenotype. Most patients had no heart failure hospitalizations in their last year of life. Most deaths were from causes other than progressive heart failure. My comments, this is super important work, and I'll just quote the authors again because they have a really nice paragraph. Quote, Most discussions about the care of patients with heart failure are focused on the treatment of the syndrome itself, with emphasis placed on a need to maximize meds and device therapy. However, most hospital admissions in the last year of life are for non-cardiovascular causes, suggesting that the needs of patients with heart failure extend beyond the optimization of treatment for heart failure. Our findings point to a need for care that is multidisciplinary, patient-centered, and coordinated between the hospital and the community. Amen. I don't know about you, but I see about 5 patients like these 75 to 87-year-olds in this paper than I do who have robust ambulatory heart failure. While I agree that when possible, we should maximize all possible therapies in patients with heart failure who are like those in the trials, but many, and I would argue most patients with heart failure are like those described from the University of Hull. For these patients, we should emphasize different things other than SGLT2 inhibitors or sacubitril valsartan. We should emphasize ways to improve their quality of life, and one sure way is to minimize the burden of being a patient. I've seen elders who fall and are losing weight, and they're told to take their blood pressure twice daily. I've seen elders who have 2 or 3 of the 4 horsemen of the apocalypse, and they're on 80 of atorvastatin. I've seen elders like these have nuclear perfusion studies. These are all failures of medicine 101. It is crazy. Most of my heart failure patients are unlike those in the trials, but we can still help them a lot. We can help them by caring and by minimizing their work of being a patient and by maximizing the things that give them comfort and joy in their remaining time. This is a great paper from the University of Hull in the UK near the sea. Last topic today is SGLT2 inhibitors and AFib. About 15 years ago, Prash Sanders and his team in Adelaide changed the world of EP by showing the importance of managing cardiometabolic risk factors. Their work really helped bring primary care back to electrophysiology, things like weight loss, management of blood pressure, glucose, sleep apnea, and exercise. All these things helped to reduce AFib, as well as increase the chance of success of AF ablation. But because it is hard to accomplish these goals, and because it is easier and far more lucrative to ablate AFib, their efforts have plateaued a bit. Yes, we still talk about it, but ablation technology steals most of the oxygen in the halls of EP science. Yet, these new drugs seem to be reviving the interest in treating AFib as a symptom of upstream cardiometabolic disorders. First, there were the SGLT2 inhibitors, which improve cardiovascular outcomes in patients with diabetes, heart failure, and reduce renal outcomes in patients with CKD. And now, of course, there are these new weight loss shredders, GLP-1 agonist. Well, Jackie P. has published an observational study from a group led by docs at the Leahy Clinic in Massachusetts. The first author is Mohammed Rashid Abu-Qaoud. Again, sorry about the pronunciation. This group from Massachusetts studied the effect of SGLT2 inhibitor use on reducing AFib after ablation. Now, notice the construction of that sentence. After talking about Bobby Ye's and Miguel Hernan's papers last week, wherein they suggest not trying to hide causal inference intentions of observational research, I chose to use causal intent in the description of this study. The authors sort of did this too. They wrote their objective was to assess the impact of SGLT2 inhibitor use on the recurrence of AFib among patients with diabetes after catheter ablation. My friends, if you haven't listened to last week's podcast, please do. And I think we should avoid shying away from causal intent in these non-random comparisons. Our job henceforth will be to assess how well the authors do it. How close is their study to a trial emulation? Now, this was a pretty simple study. They used a big database called TriNetX, and I've actually never heard of it, but it's a large U.S.-based multi-center federated research network that aggregates data from electronic health records of more than 200 million patients, more than 120 U.S. healthcare organizations. And what they did is they took patients with diabetes who had AF ablation between 2014 and 2021, and they made 2 groups, those on SGLT2 inhibitors and those not on SGLT2 inhibitors. Now, their main outcome was something that you can get from an EHR database pretty easily. Did the patient have cardioversion, antiarrhythmic drugs, or repeat AF ablation? The two groups were not that far off in baseline characteristics, which Bobby Ye says is the first good sign of an observational study. They then propensity matched them. Now, the robustness of this matching is hard to assess, for me at least, as a non-expert. Their main results were that SGLT2 inhibitor use in patients with diabetes who underwent AFib ablation was associated with a significantly lower risk of having a cardioversion, new antiarrhythmic drug, or redo AF ablation, and the adjusted odds ratio was 0.68, so a 32% relative risk reduction, which was highly statistically significant. At 12 months, patients on SGLT2i inhibitors had a higher probability of event-free survival, the hazard ratio there, 0.85, again, statistically significant. All secondary outcomes were lower in the SGLT2 inhibitor group. However, ischemic strokes did not differ between the groups. Now, one possible clue here, and I think it's an important clue, is that the mortality signal, all-cause mortality, was also lower among patients on SGLT2 inhibitor use, and the hazard ratio there was 0.62, and I'll come back to that. Now, my comments here is, okay, you know where I always start with these things. The main problem in studies like this is the risk of selection bias, wherein healthier patients get the SGLT2 inhibitor, and that is why there were fewer episodes of cardioversions, drugs, or repeat ablations. The authors indeed list this as their first limitation, and the evidence for confounding here is the mortality signal. These are young 65-year-old patients who you would not expect the SGLT2 inhibitor or any drug to have an effect on mortality. And think about it. In a non-random observational study, whenever the odds ratio for death is lower than the odds ratio for the primary non-fatal outcome, here it was repeat procedures or drugs for AF ablation, then you got to worry about selection bias wherein healthier patients get the active treatment. But on the other hand, the two groups were pretty well matched at baseline. They did have a time zero, which was the index ablation. They did propensity matching, and the data comports with RCT level data. And here I'll cite a large meta-analysis of RCTs of SGLT2 inhibitors looking at AFib. This was from the group at McMaster's. It's published in the Journal of the American Heart Association, 2021, first author Arjun Pandey. That paper pooled 31 trials of SGLT2 inhibitors that had reported on AF and found a statistically significant 25% risk reduction in AF in the SGLT2 inhibitor arms. My take home here is that SGLT2 inhibitors have proven cardiovascular benefits in diabetes and CKD and heart failure with reduced ejection fraction. These types of patients often have AFib, and when we ablate AFib in patients with these conditions, it seems wise to make sure that these patients are on these drugs, as there may be an added boost in AFib outcomes as well. Okay, final topic very briefly is that ESC is coming next weekend. I leave Wednesday for Amsterdam for the ESC Congress. This week I'll have a written preview up on the website. I'll also write a number of stories from Amsterdam. The team from the Heart.org Medscape Cardiology will have full news coverage. Now, I'll tell you, at first glance, there are going to be many interesting studies coming from ESC, so look forward to that. And of course, if you're in Amsterdam, please find me and say hello. That's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please take the time, rate, review. These little things go a long way to helping others find us. Until next week, from Amsterdam, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.